Hello friends, welcome to this OBS Gynae guest question session for upcoming FMG exam 2024. I am Dr. Harmeet Goel, your OBS and Gynae faculty, and presently I am working in Rajiv Gandhi Cancer Institute Research Center, Rohini, as a consultant gynae in preventive oncology department. Today I have come up with this session where I am going to discuss important questions which might be expected in the upcoming FMG exam 2024. It's not only the questions which I'm going to cover up, but I'm going to tell you the important key points as well, so that you are able to click the right answers in your exam. Now, presently I am keeping up the pattern which has been asked in last 2-3 exams of FMG. Plus, you can go through my videos on the NExT YouTube channel, where I have taken up a test and discussion in 2 parts, gynae and OBS, for the upcoming exam. Plus, I have also taken a live session on NExT YouTube channel, where I have discussed previous 5 years FMG exam. Those questions which have been asked in previous 5 years FMG exam, there are around 180 questions which I have discussed. So you can go through those videos as well for your bestest preparations for upcoming FMG exam 2024. So my first question is, 35-year-old female was brought to the gynae casualty in collapsed state, and history from the relative is amenorrhea 1.5 months, bleeding per vaginum and fainting. On arrival, her blood pressure is 80/50 millimeters of mercury. Bedside ultrasound was done, and there was no gestation sac in the uterus, and there was a free fluid in the pelvis. Resuscitative measures were started. What will be your appropriate step in the management? So whenever a patient comes, any patient comes in the casualty in the collapsed form, first of all, you have to revive the patient and you have to start the resuscitative measures, which includes start an IV line, start the IV fluid. The best available fluid is the ringer lactate. Then take the blood samples to arrange the blood and make a quick clinical diagnosis and proceed with the further management. Here, the history is that patient is in collapsed form where the BP is 80/50 millimeters of mercury. She presented with amenorrhea, bleeding per vaginum and fainting. And there is no gestation sac in the uterus. So probably it is a ruptured ectopic pregnancy, as the patient is in shock and the relatives are giving you history of amenorrhea, bleeding, fainting and shock. Okay, so which is the most appropriate step in management is always you have to start the resuscitation first, revive your patient and proceed with an immediate laparotomy. Because why immediate laparotomy? The options given to me. So you have already made a provisional management in your mind. Okay, you have already made a provisional management or plan in your mind, and this has to be very, very quick, and it is a team approach. So what are the options given in this question? It's perform laparoscopic salpingectomy, immediate laparotomy, give methotrexate, send beta HCG and manage after the report. So you cannot wait and watch since your patient has presented in shock. So laparoscopy is out of the scene. Giving methotrexate, which is a medical treatment for unruptured ectopic, is not applicable here because it is already a ruptured ectopic. And number 3, send beta HCG and manage after the report. We cannot wait and watch. This would have been possible if the patient's blood pressure is being maintained and her condition is stable. So we are left with immediate laparotomy because in the questions, the resuscitative measures have already been started and clinically you have made a diagnosis of rupture ectopic pregnancy, plus you have performed an bedside ultrasound which is conclusive of rupture ectopic pregnancy, that there is no gestation sac in the uterus. So the pregnancy lies outside the uterine cavity and most common probability is a tubal ectopic pregnancy, and since it is just 1.5 months, so this is around ischemic ectopic pregnancy, which usually ruptures in less than 6 weeks. So earliest to rupture ectopic, many times they have asked this question, earliest to rupture ectopic pregnancy is ischemic rupture, then late to rupture ectopic pregnancy is interstitial ectopic pregnancy, which can continue up to 3 to 4 months, and ampullary ectopic pregnancy occurring in the ampullary portion of the fallopian tube ruptures around 8 to 10 weeks. So most likely it is an ischemic ectopic pregnancy which has ruptured and patient has gone into shock. Now one more thing, if there is ectopic pregnancy in the ischemic part of the fallopian tube, ischemic part of the fallopian tube is not the narrowest part is the interstitial part, but this is again a thinner part of the fallopian tube, and usually pregnancy occurring in the ischemic part of the ectopic of the fallopian tube usually likely to rupture. Okay. Now, when it has ruptured, so there is so much of bleeding and the patient has gone into shock. So management will be immediate laparotomy followed by salpingectomy. Now, also you should remember that which are the best non-invasive investigations which you can perform. So the best will be transvaginal scan, which will tell you that there is empty uterus plus adnexal mass. Okay, if they tell you that there is cardiac activity or gestation sac present in adnexal mass, then it is very likely that the radiologist has given you a correct diagnosis. If they just write adnexal mass but there is no comment upon the gestation sac in the adnexa, then you get confused. Then you have to go for a next set of investigation, and this all is possible because your patient's general condition has been stable. Okay. This is possible when it is unruptured ectopic pregnancy. That means the patient's blood pressure is being maintained. But wherever possible, a bedside transvaginal scan can be done if you're suspecting an ectopic pregnancy. Now, which is the most dangerous type of ectopic pregnancy? This is my question number 2. Is it interstitial, ischemic, ovarian or cervical? This type of question has also been asked in one of the FMG exam. It is not that previous questions of the exam only those part is discussing. No, I am telling you additional points as well on which the exam, there may be some expected questions which can come. Okay, so the most dangerous part or type of ectopic pregnancy is interstitial. Now, what do you understand by interstitial ectopic pregnancy? Interstitial ectopic pregnancy is pregnancy growing somewhere here. So, this type of ectopic pregnancy can continue here and it can take some part of the uterus. So, before it ruptures, it can continue here. So, this pregnancy may likely to be get missed as a uterine pregnancy, normal intrauterine pregnancy. Okay, and this part is again a vascular part of the uterus and the fallopian tube. So when it ruptures, it is causing a dangerous type of ectopic pregnancy. Also, just remember, if there is an ovarian ectopic pregnancy, what is the criteria for ovarian ectopic pregnancy? It is Spiegel-Berg criteria. If it is cervical ectopic pregnancy, the criteria is Rubin's criteria. If it is primary abdominal ectopic pregnancy, then the criteria is Study Ford. And also remember, what are the points where medical treatment has to be given for unruptured ectopic pregnancy? You should revise that particular part also. Now, what is a drug for giving a medical treatment for unruptured ectopic pregnancy is methotrexate, and you should revise the criteria for the methotrexate. Next, question number 3. A 25-year-old primigravida normotensive comes at 24 weeks of pregnancy for for antenatal checkup. Now her blood pressure is 150 by 92 millimeters of mercury, but urine proteins by dipstick method is negative. What is your most probable diagnosis in this case? Okay, so blood pressure has been raised during pregnancy and the first recording is at 24 weeks because it is written in the question she was normotensive before that. Okay, so like it is a case of pregnancy induced hypertension, that because of pregnancy she has become hypertensive. So similar pattern of question has already been asked in previous FMG exam. Okay, so just to give you a clue, pregnancy induced hypertension or preeclampsia is very important topic for your upcoming FMG exam. Why it is important? Because incidence of preeclampsia in Indian females during pregnancy is around 10%, which is quite a high number, and most of the time when you are working in the clinicals you find such patients. So you should be, as a doctor, you should be able to diagnose and manage these cases perfectly. Okay, that is what is an idea of asking questions in your FMG exam. So what is your most probable diagnosis in this case? Preeclampsia, gestational hypertension, chronic hypertension, or chronic hypertension superimposed by preeclamptic changes. Since there is no proteinuria by the dipstick method, so this is a category of gestational hypertension where proteinuria is absent. And one more important point you should remember is blood pressure in these cases should be rising after 20 weeks. So when it is a preeclampsia, apart from blood pressure, there is proteinuria added. To differentiate between mild preeclampsia and severe preeclampsia, proteinuria has got no significance. It is that end organ damage. If present, it is a severe preeclampsia. If end organ damage symptoms and signs are absent, it is mild preeclampsia. Okay. So only blood pressure is raised and this is occurring after 20 weeks of pregnancy. Chronic hypertension is blood pressure present in less than 20 weeks of pregnancy, and chronic hypertension superimposed by preeclamptic changes means blood pressure is present in less than 20 weeks of pregnancy. That means it is a case of chronic hypertension and now proteinuria is being added or it is superimposed by preeclamptic changes. So friends, pregnancy induced hypertension or preeclampsia is very important points. Plus, you should remember the HELP syndrome as well, because they are asking questions on HELP syndrome and they give you a clinical question where they can write the lab investigation finding as well, and you should be able to mark the correct answer. Okay, so HELP syndrome you already know is hemolysis, elevated liver enzymes, and low platelets. So that is what is the diagnosis of HELP syndrome. HELP syndrome is a complication that is seen in severe preeclampsia patients. Okay. Then you should know another important question, that is which of the following is not used in preeclampsia. So similar question has already been asked in one of the FMG exam. Okay. So options given to me are methyl dopa, atenolol, labetalol or hydralazine. So atenolol is not being preferred in cases of preeclampsia. So the preferred drug is labetalol, which is our first line drug for hypertension occurring in pregnancy. This is very useful when there is acutely raised blood pressure. It's also a wonderful drug in cases of hypertensive crisis occurring in pregnancy. It's also been used for chronic hypertension in pregnancy. So the safe antihypertensives that are used in pregnancy includes labetalol, it includes nifedipine, and number 3, that includes hydralazine and even alpha methyl dopa. The only drawback with alpha methyl dopa is that onset of action is very much delayed, but comparatively all these drugs are the safe antihypertensives, and if it can be given to the chronic hypertensive patients who are pregnant, then again it does not cause any teratogenic effect. One more thing, if the blood pressure is very raised and patient has come up with hypertensive crisis, you have started with labetalol IV. Advantage with labetalol is it can be given IV or it can be given oral. Both ways it can be given. And if it is hypertensive crisis, blood pressure is very high, for example 180 by 120 or more, then you start with IV labetalol, and every 10 minutes you can increase the dose to maximum 220 milligram per hour. Okay, and you can add on nifedipine, but remember, nifedipine should not be given by sublingual route. It is to be given oral with a sip of water. Okay, if still blood pressure is very high, again you have to start with magnesium sulfate in cases of severe preeclampsia where there is warning symptoms present like headache, blurring of vision, etc., because your patient might throw fits. Okay, so remember, when it is a severe preeclampsia with impending signs of eclampsia like headache, blurring of vision, epigastric pain, etc., then do not forget to start the anticonvulsant as a prophylactic measure. Okay, if the blood pressure is not getting control on the antihypertensive you have started, so you can add on nitroglycerin drip. Fine. Now, which antihypertensive is contraindicated in pregnancy? You know, it is ACE inhibitors like enalapril, lisinopril, etc. Why they are contraindicated? Because they cause teratogenic effect. If it is given in the first trimester, it causes teratogenic effect. If it is given in the second or third trimester, it causes placental insufficiency or hypoxia, chronic hypoxia. Next, question number 5. A 35-year-old female was brought to the casualty with history of 5 convulsions at home. Now her blood pressure is 180 by 120. So this is a case of eclampsia. Okay, convulsions at home, and when she is brought to the casualty, the blood pressure is persistently raised plus convulsions. Okay, it is not epilepsy, because in epilepsy blood pressure is not raised, so it is eclampsia. What will be the best management for her? Labetalol plus magnesium sulfate alone, or immediate cesarean section. Friends, always when there is an eclampsia, you are supposed to terminate the pregnancy. But termination of pregnancy does not mean that you have to take the patient for immediate cesarean section. No way. First of all, stabilize your patient. If it is unconscious still when she is brought to the casualty, then always maintain the airway first, because you will load the magnesium sulfate and patient will be loaded, because tongue can fall back and she can aspirate, and she can die of aspiration. So always remember A, B, C. Airway, breathing, and circulation. So in cases of ruptured ectopic pregnancy, I mentioned always restore the circulation, let the patient come out of the shock, and simultaneously do rule out the cause and try to treat the cause. Okay, so resuscitation and laparotomy I mentioned for ruptured ectopic. Here the patient, if brought in unconscious state, always maintain the airway first. Okay, so in this question it is not written, it is just that she has 5 convulsions at home, but presently her blood pressure is severely raised. So you have to start the antihypertensive labetalol and anticonvulsant magnesium sulfate together. Okay, so the correct answer is labetalol plus magnesium sulfate. Fine. Then you should know the antidote of magnesium sulfate if there is toxicity. So that is calcium gluconate. Then you have to know the safe therapeutic level of magnesium, that is 4 to 7 milliequivalents per liter. What is the first sign of magnesium sulfate toxicity? Answer is absence of knee jerk. So these are important points you should remember about eclampsia management as well. Now, next question number 6. A 25-year-old priming gravida at 35 weeks of pregnancy is brought to the casualty with convulsions and her blood pressure is 180 by 114. So it is again a case of eclampsia. What will be the immediate first line of management? She is brought and she is having convulsions at present. Okay. So what did I mention in the previous question? Are you going to start immediately as a first line management magnesium sulfate or immediate cesarean section or give labetalol or maintain the airway first? So as I have already mentioned the importance of the maintaining the airway. So please maintain the airway first when you're managing the cases in clinicals. This is what we have learned when I was doing MBBS from Lady Hardinge Medical College or I was doing my post-graduation from VMMC Safdarjung Hospital. The eclampsia room was separate. Okay. And this is how we were taught in the clinicals. So all of you are the qualified doctors and after you write your exam and you clear your exam, you will be working in the hospitals. So this is very, very important for you to learn at this point of time. Now, next question number 7. Anti-epileptic with the least teratogenic effect, okay, in pregnancy. So now they are asking about epilepsy. Okay, so is it lamotrigine, levetiracetam, sodium valproate or phenytoin? So least teratogenic and the drug to be given is levetiracetam. So this is one of the important questions which they have asked. Sodium valproate causes teratogenic effect, okay, in pregnancy. Next, drug of choice for status eclampticus, it is thiopentone sodium. Anti-epileptic of choice in pregnancy with least teratogenic effect, I just mentioned levetiracetam. And drug of choice for raised intracranial tension in pregnancy is mannitol. So just remember these. If by chance there is single liners being asked in your FMG exam, so that will be a bonus for you. But the trend is mostly the clinical questions. Now, question number 8. Now I'm taking up from topic of twins. Pre-eclampsia and eclampsia I've mentioned. Ectopic pregnancy I mentioned. Now next I'm discussing some important points from the topic of twins. So this is a recently asked question in the FMG exam. If the division of the fertilized ovum occurs between 9 to 12 days after fertilization, name the type of twins. If it is occurring within 72 hours, although in the question this part was not given, okay, so I just remove these parts. So while I was typing the questions, by chance I just typed the explanation, okay. So just take it this question like this. Now if the division of the fertilized ovum occurs between 9 to 12th day after fertilization, name the type of monozygotic twins. Name the type of monozygotic twins. So diamniotic, dichorionic, diamniotic, monochorionic, monoamniotic, monochorionic or conjoined twins. So diamniotic, dichorionic is when it is occurring within 72 hours of fertilization. If the division is occurring between 4th to 8th day after fertilization, it is diamniotic, monochorionic. If it is occurring after 8th day, it is monoamniotic, monochorionic. If it is occurring after 13th day, it is conjoined or Siamese twins. So looking at the present question, so the answer fitting in is monoamniotic and monochorionic twins. Now, the most common variety of twins is dizygotic twins and the another variety is monozygotic twins. Okay, dizygotic twins. Okay, two ova are fertilized by two different sperms. So their genetic characters are different. HLA typing is different. They may be of same sex or may not be of same sex. But monozygotic twins are always of the same sex. So dizygotic twins have just one variety, diamniotic and dichorionic. Whereas monozygotic twins have got 4 varieties. So this is the most commonly asked question again and again in FMG exam since 2013 onwards. Every same exam or the alternate exam of FMG, this question is being asked. As far as the chances of survival, so the chances of survival is better in dizygotic twins because they are diamniotic and dichorionic. Okay. Next, what is the best time to do ultrasound to diagnose twin pregnancy? Answer is 10 to 12 weeks. So that is the best time to do an ultrasound to diagnose the twin pregnancy. Question number 9. A 25-year-old female presents with 8 weeks amenorrhea, bleeding per vaginum. On examination, cervix is open. Okay, cervix is open and bleeding per vaginum is present. Size of the uterus is equal to the period of gestation. POCs are not expelled. That means the POCs are being felt, but they are not expelled as yet. But cervix is open and bleeding is present. Bleeding is present. When cervix is open, POCs are felt, products of conception are felt, but they are not expelled. Size of the uterus is corresponding to period of gestation. This type of abortion is inevitable abortion. This type of abortion is inevitable abortion. So let us see what are the options given to us. So name the type of abortion: threatened abortion, inevitable, incomplete or complete. So as the history and examination and findings suggestive, this is inevitable abortion. Okay. Now, if in the history there is amenorrhea, there is bleeding, size of the uterus is equal to period of gestation, ultrasound shows cardiac activity present, then that type of abortion will be threatened abortion. Pregnancy is threatening to abort, but it does not abort. And you can save this pregnancy by giving progesterone support. Okay, you can save this pregnancy by giving progesterone support. Number two, I have already discussed inevitable abortion where no products have expelled and cervix is open. Okay. Third type of abortion is incomplete abortion where POCs have expelled and some are hanging out in vagina. Hanging out in vagina. This type of abortion is incomplete abortion. Now, for inevitable and incomplete abortion, the management is D&E by using ovum forceps. So sometimes if they want to ask a question, management, then you should be able to answer that threatened abortion. If cardiac activity is present on ultrasound, you can save that pregnancy by giving progesterone. And when it is inevitable or incomplete abortion, then the management is D&E using ovum forceps, or they can ask you the instrument that is ovum forceps as well. Now, question number 10. Then also you should know the most common cause for first trimester abortion is chromosomal, and like most specific for first trimester abortion is monosomy. Fine. If it is most common cause, then it is trisomy. Then most common cause for second trimester spontaneous abortion, that is cervical incompetence. Fine. Next, all of the following are important indications for MTP except. This is again an important question on the topic of abortion. MTP, APH, PIH, they are constantly asking questions in the previous FMG exams. So kindly prepare these topics very well. Now, all of the following are indications for MTP except condom failure, rape victim, twin pregnancy, mother having serious medical disease. Condom failure is a contraceptive failure, so you should do MTP. Rape victim, no questions, just do MTP. Mother having serious medical disease, so you should go for an MTP. But twin pregnancy, no way is an indication to perform MTP. Fine. Now, you should know new MTP Amendment Act 2020 or 2021. Okay. So, in that case, you have to understand that the upper limit for MTP has been increased to from 20 to 24 weeks, and they are usually asking questions on, like, when do you require one doctor opinion or two doctors opinion according to the latest MTP Amendment Act. So you should be able to answer that. Fine. Now, next question number 11. A 23 weeks married pregnant female was diagnosed with fetal malformation as a single ventricle in the heart, which is not compatible with life. How many doctors' opinion will be required and whose consent is needed? So similar question has been asked. So I have just changed the statement of the question, okay, which was asked in your 2023 July FMG exam. So the options are take mother consent and one doctor opinion, don't need husband consent and you just need one doctor opinion. So it is 23 weeks. So when the pregnancy is between 20 to 24 weeks, you require two doctors opinion. Okay, so now you are stuck up between the mother consent and the two doctors opinion, husband consent and a two doctors opinion. Never the husband consent is needed for MTP. So the correct answer is mother's consent and two doctors opinion is the one which is needed. So mother's consent and the two doctors opinion is needed. So why I have added up? I could have taken just a short session of 30 questions, but agar usme se questions nahi aaye to, that is why all the important topics I am covering in this session, so that there should be a surety that what way you have to give a final revision in the subject of OBS and Gynae for your upcoming exam. Remember, I have already been telling you that your 10 to 15% paper in FMG exam is OBS and Gynae. So OBS and Gynae is very, very important for passing your FMG exam. Next, question number 12. Second gravida para 1 L1 with 1.5 months amenorrhea comes to Gynae OPD asking for abortifacient tablets. So she is nearly 6 weeks pregnancy and she is asking for an abortifacient tablets. Which of the following cannot be used? So they have asked a question on abortifacient tablets on 2022, 2021 and 2023 previous FMG exams. So I have added up this question. Now misoprostol, but on those questions the options were a little bit changed. Okay, so I have created a new question for you so that it can be a guess question. Now misoprostol, mifepristone followed by misoprostol, methotrexate and all are applicable. So remember, when it is just abortion by tablets, we require mifepristone followed by misoprostol. Methotrexate is given in the list, but methotrexate we are not using as an abortifacient tablet. So the correct answer is mifepristone followed by misoprostol. Now question number 13. So I have covered up the topic of MTP and abortions both. Now I am taking up the topic of APH. So important topics I am covering it here. So I am adding up 2 or 3 questions and related points of the particular topic. Topic wise I am covering. So I have tried my best to keep the questions together. If one topic I am discussing, all 2-3 questions topic wise I am covering, not just kabhi ek topic kar rahe hain, kabhi beech mein dusre topic ka question aayega, not just like that. So I have really taken a time to prepare this PPT for you. Now in the image given below, name the type of placenta previa. So similar question has been asked in your previous FMG exam. So type 1, type 2, type 3 or type 4. If you see clearly in this image, there is a placenta which is in the lower uterine segment. So it is a placenta previa, no doubt. Okay, and number 2, that some part of the placenta is just reaching the internal os, but it is not covering. When it is reaching the internal os and it is not covering, that is type 2 placenta previa. So it is a question, according to this question and image, it is a type 2 placenta previa. Now just have a look. Normally the placenta is in the upper uterine segment. When it is reaching, like the os, it is type 2, or we call it as, like marginal placenta previa. When it is covering the os, we call it as partial placenta previa, which is type 3. And when it is totally covering the internal cervical os, that is a central placenta previa, or it is a complete placenta previa. So in this question, either you call it as marginal placenta previa or it is a type 2 placenta previa. Okay. Now, question number 14. A 28-year-old female G2P1L1 presented at 34 weeks of pregnancy with a history of painless vaginal bleeding at home, and she has ultrasound report of last week showing a low-lying placenta. Okay, so that means she has come up with a third trimester bleeding. So this is placenta previa. Okay, and the ultrasound report she's been brought along with is again a recently done ultrasound. So I am not going to repeat the ultrasound, because any ultrasound after 28 weeks, the placental site is fixed. So if it is a type 1 or type 4, it is not going to change. Okay. Now, per abdomen uterus is relaxed, fetal heart rate is regular, there is no active bleeding. What is your management? So it is away from term. Term, we take it as 37 completed weeks. Presently, she is not bleeding actively. Maternal condition appears to be stable and fetal condition again appears to be stable. So I am just going to do a conservative management. So send her for an ultrasound? No way. Do cesarean section? No. So I am going to put her on conservative management, which is called as expectant management for placenta previa. And name of the expectant management for placenta previa is called as McAfee-Johnson's management. So students, just read what is McAfee-Johnson's management, where you are doing a conservative management. You are going to admit the patient, put her on bed rest. Okay. You can start the IV line. You can send the investigations. You can arrange the blood. If she might be bleeding, you can do maternal and fetal monitoring. Okay, maternal and fetal monitoring. You can take a consent for LSCS. You can give her tocolytic agents, etc. So this is what is a McAfee-Johnson's management, that you are keeping everything ready. If she has again bout of bleeding, that you have already hospitalized this patient and you can start the blood transfusion if needed. You're sending the investigation to know the status of the hemoglobin. If it is less or she is already having moderate to severe anemia, you can give blood. Okay. You are taking a consent for cesarean section if, like fetal heart, like dips down, or if it is a maternal vitals which is getting deranged. So in that case, you can take a step towards termination of pregnancy. So such management is called as conservative or expected management, which is McAfee-Johnson's management. Now, question number 15. A pregnant woman, gravida 3 para 2L2A0 at 32 weeks of pregnancy comes in the emergency with a severe abdominal pain and she has bleeding. So when there is pain and there is bleeding, and this is third trimester, pain and bleeding, on examination there is tender uterus. So what is this type of diagnosis? This type of diagnosis is abruptio placentae. This type of diagnosis is abruptio placentae. So fetal heart rate is absent. That means in the uterus there is separation of the placenta which has taken place and there is internal bleeding. So this is abruptio placentae. Fine. Next, question number 16. A 30-year-old female delivered a child vaginally. I am covering the obstetrics first and then I am adding up the questions of gynae. So 30-year-old female delivered a child vaginally. Placenta was delivered completely with intact fetal membranes. After that, uterus fails to contract and injection oxytocin given, uterine massage was carried out and no success. What is the next step in the management? So this is a case of atonic PPH and placenta has been delivered with intact fetal membranes. So there is no question of retained placenta. So it is atonic PPH. So uterine massage has been done, oxytocin has been given, and no success, what is your next step? Take her for hysterectomy, do B-Lin sutures, balloon tamponade, or shift for uterine artery ligation. So before shifting for a uterine artery ligation, I am going to do a balloon tamponade. So in the question, only oxytocin has been written. It's not been written you are giving any prostaglandin has been given injection or a misoprostol per rectal or sublingual tablet, or methergine has been given. So we will assume that that must have been given. So before the medical steps end and before the surgical step, there is a second step which is called as where you can go for like balloon tamponade kind of thing, okay, which is called as a mechanical steps. Okay, so number one is the medical steps, and it appears that medical steps have failed. Number three is the surgical steps. Surgical steps include the B-Lin sutures, uterine artery ligation, and finally hysterectomy. There is steps which is called as mechanical steps or mechanical compression. So we are going to take like a Bakri balloon tamponade. So the capacity of Bakri balloon is 500 cc. So we will fill this like Bakri balloon, and we can fill it with 500 cc of normal saline to cause a compression hemostasis, so that to manage before we can take up a step of surgery. Okay, so this is management for atonic PPH. So this is very, very important topic. Complications of third stage of labor, where it includes PPH, it includes acute inversion of uterus, amniotic fluid embolism, third stage PPH, then any perineal tears, etc., or placenta, adherent placenta, which is placenta accreta. So do revise this topic. Question number 17. An intern conducts a delivery. Immediately after delivery, the mother experiences breathlessness, hypotension, tachycardia, collapses. And per vaginum examination is normal and there is no excessive blood loss. If there is no excessive blood loss, it is not postpartum hemorrhage. So postpartum hemorrhage, the mother do not experience such as breathlessness or cyanosis or she collapses, nothing like that. So it is not PPH. DIC does not occur like this, and there has to be some history of placental abruption or a dead fetus or a septic abortion, something like that. Only then we will think of a DIC condition. So it is not uterine inversion, because if it is a uterine inversion, they will write that patient has gone into shock, which is out of proportion of blood loss. Or they might write that, something clinically like mismanaged third stage of labor, which is again not written in the question. So this is purely a case of amniotic fluid embolism. Okay, might be in the question a word cyanosis is missing. Okay, which has to be, I think, should have been given in the exam question. Okay, so this is, remember, an amniotic fluid embolism. Now, question number 18. All of the following are the markers for quadruple test for aneuploidy. Nowadays, triple test has been outdated, and an integrated markers has been done for the first trimester, 2 markers like beta HCG and pregnancy induced plasma protein, along with a nuchal translucency ultrasound. In the second trimester, a quadruple test has been done, and if needed, if the finding is positive or suggestive, then an invasive method can be done. So what are the 4 markers in a quadruple test? Quadruple test, which is done around 16 to 18 weeks, that is a second trimester. It includes doing an alpha fetoproteins, beta HCG, then serum estriol and inhibin A. So these are the markers for the quadruple test, where alpha fetoprotein decreases, beta HCG rises, estriol decreases, and inhibin A rises. This is for aneuploidy, that is trisomy 21. So let us see what are the options given to us. So simultaneously I am telling you, because there might be a question. Nowadays triple test is been replaced by a quadruple test. So either they can ask you the first trimester markers, or they can ask you an image of the nuchal translucency, or they can ask you that there is a history of Down syndrome and presently this lady is positive, where nuchal translucency is come out to be positive. Then what is your next step, where chorionic villus sampling or amniocentesis would have been the answer. Okay, so please be ready with those type of questions as well. So here let us see what are the options: beta HCG, unconjugated estriol, alpha fetoprotein, and inhibin. So by chance I was typing this question instead of this estriol, I wanted to type estradiol. So wrong answer will be estradiol. So I've just told you what are the 4 markers for quadruple test. So wrong option would have been estradiol, or pregnancy induced plasma protein, which is first trimester marker for aneuploidy. So remember, quadruple test includes alpha fetoproteins, beta HCG, estriol, and inhibin A. Now this maneuver, so take it as question number 19. So I just wanted to tell you all the 4 grips. Although first grip, this is a Leopold's maneuver, and they are very fond of asking question on Leopold's maneuver. Okay, now first grip is called as the fundal grip. Second grip is called as the lateral grip. They can give you the complete image and they can ask you what is this maneuver. So your answer is Leopold's maneuver. Or they can just write the third grip and just this much image and they can ask you what is this grip. This is called as Pollick grip. Pollick grip is for presentation. Presentation means cephalic presentation or podalic presentation. So presently this is a cephalic presentation, and fourth grip is a pelvic grip, which is for engagement. The head is engaged or it is not engaged. So you can get, friends, a complete Leopold's maneuver, or you can get one of the cropped image of any of the grips and they can ask you. So just revise. First grip is a fundal grip, second is a lateral, third is a Pollick, and fourth is a pelvic grip. Now, question number 20. Now, all of the following are the causes of non-immune hydrops fetalis except, okay, ABO incompatibility, parvovirus B19, thalassemia, or sickle cell anemia. So, ABO incompatibility is the answer, as ABO incompatibility can cause immune hydrops fetalis, and important cause of immune hydrops fetalis is Rh incompatibility. Okay, so do revise the torch group of infections as well. Like most common cause for congenital infection is cytomegalovirus. Most teratogenic viral infection is a rubella, and if it is a rubella, then there is MTP mandatory in that case. Okay, next question number 21. Identify the type of pelvis given in this image. Is it a gynecoid pelvis, android pelvis, anthropoid pelvis, or platypuloid pelvis? So students, since it is, let me show you the image. So this image appears to me as a gynecoid pelvis, which is a normal pelvis. Okay. So they can ask you about anthropoid or android type of pelvises as well. So just see, gynecoid pelvis is a normal pelvis, and android pelvis is called as heart-shaped pelvis, or it is a male type of pelvis where the transverse diameter is shortened than the anteroposterior diameter. So there is deep transverse arrest which can occur. Okay, so deep transverse arrest occurs in occipito-posterior position, and management of deep transverse arrest is cesarean section. Management of deep transverse arrest is cesarean section. Anthropoid pelvis is like this, where again the transverse diameter is shortened. So again deep transverse arrest can occur in anthropoid as well. But anthropoid pelvis, usually the question is, like face to pubis delivery or persistent occipito-posterior is more common in anthropoid pelvis, and platypuloid pelvis, like face or brow presentations are common. Okay, so most of the time whenever they have asked a question in FMG exam, they can ask you that deep transverse arrest is seen in which type of pelvises. So your answer is android pelvis. Fine. So just remember these 4 images. Now, question number 22. Which of the following is not contraindicated for a normal vaginal delivery? Previous to LSCS, previous macrosomia, previous classical cesarean, or contracted pelvis. Previous LSCS, it has to be a cesarean section. Previous classical cesarean, again an absolute indication for cesarean. Contracted pelvis, again pelvis is not going to improve, so it is a cesarean section. Where previous macrosomia, you might have done a cesarean, not necessary that present pregnancy will also be a macrosomia. So that is not an indication. You can allow a normal vaginal delivery in that situation. Okay, next. Question number 23, and this question has been asked in this year, like July FMGE exam. Now, identify the forceps: outlet, keel end, Piper's, or Das forceps. What is your answer? Now, it appears to me these are the short curved forceps. This appears to me as the short curved forceps with no axis traction device and the small handle. So this appears to me as an outlet forceps, and name of the outlet forceps is Wrigley's forceps. Okay, so this is outlet forceps. But again, I have added up an explanatory slide where I am going to show you the keel-end forceps, Piper's forceps, and Das forceps. Presently, like all the difficult forceps has been banned, okay, because the couple are going for just 1-child norm or a 2-child norm. So every pregnancy in modern scenario or modern times is a precious pregnancy. Okay, so difficult forceps has got no role. If you can apply safely, you can apply only the outlet forceps. So just have a look. This is the Das forceps with an axis traction device. This is no longer used. Then this is keel-end forceps, which was used for deep transverse arrest. This was forceps rotation and delivery. This is again outdated. Okay, this is again outdated. This is Wrigley's forceps, which is outlet forceps. This is Piper's forceps, which is for after coming head of breech. Okay, next. The outlet forceps has got an English lock. Keel-end forceps no longer used, which has a sliding lock, and Piper forceps was used for like after coming head of breech, and it has a reverse pelvic curve. Okay, so these only the outlet forceps are in use. These two are no longer used. Question number 24. So, why I have added up this question, because students do not read and they do not know what is an obstetric audit term means. It includes all except, this is a question which was asked, fetal death, injury to the mother, injury to the fetal head. So all this is included. There has to be audit why the maternal death occurred and why the fetal death occurred, all injury to the fetus, but preterm labor is not included for obstetric audit. Fine. So maternal deaths, infant deaths, severe morbidity, number of cesarean, number of instrumental delivery, all this is included in the obstetric audit. So please do read this topic as well. Now, question number 25. So this is gynecology part, or you can consider it to be in obstetrics, because some of the topics of obstetrics are still pending. A lady presented with 3 months amenorrhea with excessive vomiting on examination. Fundal height is 16 weeks. So fundal height more than the period of gestation, and uterus is felt soft. That means no fetus felt. All of the following are correct statements except, and there's an image also given. This appears to me an ultrasound image which shows snowstorm appearance. And snowstorm appearance, is a molar pregnancy. Okay, so ultrasound shows snowstorm appearance. This is correct. Beta HCG to be done, yes. Chest X-ray to be done, because there is a risk of developing gestational trophoblastic neoplasia. So chest X-ray we want to keep as a basal investigation. Methotrexate is given. This is a wrong answer. If it is a molar pregnancy, I am going to do a suction evacuation. Okay, not methotrexate. Okay, next question number 26. Best ultrasound parameter for assessment of gestation age. So they have just included the ultrasound parameter. So always in the first trimester, it is the crown rump length. In the second trimester is the BPD, and in the third trimester is the femur length. So here gestation age is not been mentioned. So I'm going to mark the answer as crown rump length. So first trimester I have told you the crown rump length, and after that BPD, and third trimester is femur length. When you want to find out fetal growth, then abdominal circumference, or fetal macrosomia, then abdominal circumference. That is the best parameter to be considered. Now, question number 27, I have not given you any question because I wanted to add up this explanatory slide. So the normal physiological changes that are occurring in the heart is apex beat is shifted towards left. There is loud heart sound, split S1, ejection systolic murmur up to grade 2. These are the normal physiological changes. But if there is a cardiomegaly or split S2 or ejection systolic murmur, grade 3 or more, or a diastolic murmur or a raised JVP, then that is considered as abnormal, and you should make a diagnosis of heart disease which you have diagnosed in pregnancy. Okay, so similar question might be expected, can come. Next, question number 28. Shoulder dystocia is managed by all of the following except Zavenalis, suprapubic pressure, Wood's corkscrew method, or fundal pressure by the abled nurse. So fundal pressure is never given in a case of shoulder dystocia. Shoulder dystocia is usually a complication that is seen if a macrosomia baby is allowed to deliver normally. So what happens, that head of the baby is being delivered and the shoulders are getting stuck up. So that is called as shoulder dystocia. In that case, you will do the Mac-Roberts maneuver. You can apply the suprapubic pressure, you can do Zavenalis maneuver, Wood's corkscrew maneuver, but fundal pressure is not being done. It is absolutely contraindicated, because if a nurse is giving a fundal pressure, then the asphyxia will result and baby will die immediately. Okay, so this is question number 28. Question number 29. What are the side effects of oxytocin bolus over oxytocin infusion in a pregnant woman occurring in labor? Is it hyperglycemia, hypoglycemia, hypotension, or maternal seizures? When IV bolus is been given, it can cause hypotension. Next, question number 30. A prostate gland is homologous to which of these structures in the female? Skene's gland, Bartholin gland, apophoron, or Gartner's duct? Apophoron or Gartner's duct are the remnants of Wolffian duct in the female. Wolffian duct in the female, because Wolffian duct derivatives are being formed in the internal genital organs in the male fetus. Okay, so when it is a prostate gland is homologous with glands of Skene, and Bartholin gland in the female is homologous with Cooper's gland in the males. Cooper's gland in the males. Okay. Next, question number 31. A lady presented in gynae OPD with complaints of foul-smelling vaginal discharge and there is no itching. Senile microscopy shows clue cells. So friends, clue cells is seen in bacterial vaginosis. All of the following are correct statements except plenty of lactobacilli, VIF test is positive, normal flora has been replaced, no need to treat the partner. So all these three statements are the correct statements about bacterial vaginosis, but wrong statement is plenty of bacilli. What is a normal flora of vagina? Is the Dodderlin bacillus, which is a lactobacilli, and lactobacilli is responsible for making the pH of vagina acidic to inhibit the growth of pathogens. So whenever the lactobacilli are being replaced by Gardnerella vaginalis or by Mycoplasma or by Haemophilus. The condition occurs which is called as bacterial vaginosis. So pH will be more than 4.5. Lactobacilli are being replaced. Clue cells are seen in saline microscopy. Whiff test is positive and this is not STD. So this is what is the correct statements about bacterial vaginosis. Bacterial vaginosis is a very commonly asked question. Next, question number 32. Amsel's criteria is been used for, I have just mentioned Amsel's criteria, that is for bacterial vaginosis. And drug of choice for bacterial vaginosis is metronidazole, and there is no need to treat the partner. Best way to differentiate between complete mole and partial mole is by karyotyping. In complete mole, it is a diploid. Partial mole is a triploid. Abnormal chromosomes are paternal in origin. So if they ask you questions between a complete mole and partial mole, these are the most commonly asked questions. So I am giving you in the form of single liners. So take it as question number 33. Now, question number 34, this is I am discussing in the form of single liners. Management of H-mole in a young patient is suction evacuation. Beta HCG is needed for follow-up. Most common GTN developing after an H-mole evacuation is a residual mole. And best contraceptive in the follow-up cases after a GTN is always oral contraceptive pills. So again, you can use these points as a single liners if by chance they ask you a question in the form of single liners, so you know the answers. Okay. Now, question number 35. So I am switching over to the gynecology part. If there is any OBS question being come, I am going to discuss. So most of the part which is important I have covered up in obstetrics. Now, a lady with infertility undergoes a laparoscopy for the purpose of assessment of pelvic anatomy. For a tubal patency, a chromatization has been done by pushing a cannula. What is the name of the cannula we use for doing, HSG? For HSG, it is a leash Wilkinson cannula, which they have already asked in FMGE exam, and I have already discussed that in the 5-year PYQs. So you can go through that videos as well as. So if you just go through the videos of OBS and Gynae TND at NExT YouTube channel, 5-year PYQs of the FMGE exam on the NExT YouTube channel, and this guest questions of OBS Gynae, your preparation for OBS Gynae will be perfect, and I'm sure 100% all questions of OBS and Gynae you will be able to short clear with correct answers. Okay, so just go through these 4 videos which I am just mentioning. So this is exclusively available on NExT YouTube channel. So the cannula is being introduced in the cervix and a dye is being injected, and we want to check up the patency of the fallopian tube. Now, which is a dye used for laparoscopic chromatization? It is always a methylene blue dye. Okay, it is always a methylene blue dye. Now, you can see this is a normal HSG image where you can see free spill of a radio opaque dye. Radio opaque dye we use is urographene, and the cannula we use it leash Wilkinson cannula to perform HSG. Okay, and this is laparoscopic chromatization. You can appreciate the blue color liquid in the pouch of Douglas. Okay, now question number 36. A 45-year-old female coming up with a history of something coming out of vaginal introitus, backache, vaginal discharge. On examination, there is uterine prolapse, ulcer at the dependent portion of cervix. So this is a case of decubitus ulcer. Decubitus ulcer that is occurring in the dependent portion of cervix. This is a genital prolapse. So friends, Why I have taken up the reverse mode? Because when we are taking up the sessions, mostly we are discussing disorders of menstruation or a contraception or an ectopic pregnancy, and the topics like genital prolapse, urinary fistula, they get missed out, where they are now asking questions, 1 or 2 questions in your exam. So you already have revised a lot with me in OBS and Gynae on the topics of disorders of menstruation, contraception, infertility, ectopic pregnancy, cancers. So that is why I am discussing these topics first in the session of Gynae. Okay. So what is the management of decubitus ulcer is always packing. You can take a tampon, dip in glycerin, acreflavin solution and do the packing. Glycerin is hygroscopic, absorbs water and reduces edema, and acreflavin is antiseptic. So, like there is a role of packing. So, in this question, by chance, I have just missed out. So, what you have to do? You have to do, take a tampon, dip in glycerin, acreflavin solution and do the packing. So, that is what is the correct answer. Now, question number 37. So, you take it as a single liners. To the single liners, I am just giving one question. Okay. If there are 10 single liners, I cannot write these are the 10 questions. Fine. This is just a bonus points for you. If you get such a questions in your exam, like you are very happy because most of the time you read single liners. But mind it, I am discussing the clinical questions. I am discussing single liners. I am telling you the important key points and I am adding up the images. So मेरे हिसाब से पूरा मसाला मैंने इस सेशन में डाल दिया. ठीक है. So LH surge occurs 24 to 36 hours before ovulation. LH peak occurs 10 to 12 hours before ovulation. Hormone responsible for LH surge is estradiol peak and more than 200 picograms per ml. If this hormonal levels is more than 200 picograms, then LH surge will definitely occurs and this is confirmatory for ovulation. Regular heavy menstrual cycles is called as menorrhagia. Frequent menstrual cycle is called as polymenorrhea and prolonged cycles is called as oligomenorrhea. Size of the dominant follicle before ovulation is 18 to 20 mm. This you check it on transvaginal scan. Best investigation for ovulation is TVS or ultrasound follicular monitoring. Corpus luteum secretes which hormones? It secretes progesterone, but it also secretes estrogen as well. Okay. So this is my question number 37. Question number 38. A mother brought her daughter to the gynae OPD with complaints of not attaining menarche. Hormonal studies, normal FSH and LH. Examination shows normal breast and normal pubic hair. That means ovarian function is normal. Okay. And if pubic hair are present, it is not androgen insensitivity. Ultrasound shows small blind vagina and absent uterus. Karyotype is 46XX. So this is a clear-cut hint in this question. Is it a Turner syndrome, androgen insensitivity? It is not androgen insensitivity. It is not Turner because breast development is present. So this is purely Mullerian agenesis. Plenty of times in my revision classes or on my test and discussion sessions, I have discussed such type of questions. So please do revise. Okay. Next, take it as question number 39. Karyotype for Mullerian agenesis is 46XX since uterus is absent and ovary are present. Karyotype of Turner syndrome is 45XO and there are streak gonads. But uterus is present and it is hypoplastic and there is no breast development because there is no estrogen. Karyotype for androgen insensitivity syndrome is 46XY and there is undescended testis. There is no uterus. There is breast development normal. there is no axillary hair and no pubic hair. Okay. Next, question number 40. Example of male pseudo-hermaphrodite. Answer is androgen insensitivity syndrome or testicular feminization syndrome, and also sphere syndrome. Name of female pseudo-hermaphrodite is adult onset congenital adrenal hyperplasia. Okay, you can say it is congenital adrenal hyperplasia. Treatment for androgen insensitivity syndrome and sphere syndrome is gonadectomy because there is undescended testis and that is a risk for testicular tumors. So you can save the patient from testicular tumors by doing a gonadectomy. Okay. Now, question number 41. This is again a very, very important topic and like point or a question because it has been asked 2017, 2020, 2022. So this is very important. A young female presented with primary amenorrhea, cyclical pain abdomen every month, no visible bleeding, and there's a bluish membrane bulging. So this is no other than imperforate hymen, also called as hematocolpos. Since whole axis is normal and menstrual blood is collected in the cervix or vagina, that is called as hematocolpos, or this is also called as congenital cryptomenoria. Congenital cryptomenoria. So imperforate hymen or hematocolpos or congenital cryptomenoria, and the treatment for this is cruciate incision and drainage. Treatment for this is cruciate incision and drainage. Question number 42. A female has undergone a DNC for missed abortion. After that, she has developed secondary amenorrhea. So I have already told you when there is an excessive curettage in the form of DNC and this is leading to secondary amenorrhea and FSH being normal. If you are given with these 3 points, just grasp the hint. What is this? This is because of a vigorous curettage performed during DNC, there is formation of adhesions leading to secondary amenorrhea and infertility. So this is no other than Asherman syndrome. So you have to grasp the hint, make a clear-cut diagnosis in your mind and just look at the options. It is not TB, it is not PCOS, it is not Sheehan's. So it is Asherman syndrome. And what is the gold standard investigation for Asherman syndrome? Your answer is hysteroscopy. Okay. So first of all, you are going to do an HSG. On HSG, you see that there is irregular filling defects. Irregular filling defects. And finally, you go for a gold standard investigation, that is hysteroscopy, because with hysteroscopy, you can do adhesiolysis. With hysteroscopy, you can do adhesiolysis. Okay. This is question number 43 where they can ask you an image-based question. In this case, they will write that this is a case of primary amenorrhea. What is your diagnosis? You can see there is congenital webbing of neck. There is cubitus valgus deformity. There is no breast development. Short stature you cannot judge from the image, and there is low posterior hairline and a short fourth metatarsal. So this is Turner syndrome. Now you can get a karyotyping of Turner syndrome or you can get a karyotyping of Down syndrome. Either the Turner syndrome or the Down syndrome. So you should be able to understand the karyotype. You can see in the sex chromosome there is just one X. So this is 45XO, which is Turner. If it is 3 chromosomes at 21, then that will be trisomy 21, that is Down syndrome. If there are 3 chromosomes at number 18, then that is Edwards syndrome. and if it is 13, so some of the chromosomes are missing while this image was cropped, so some of the chromosomes got missed out. But you know, like, you should be able to get, there will be a very clear cut image in your exam question. Then they have asked a question that what is the type of congenital heart disease in Turner? So it is a bicuspid aortic valve. It is a bicuspid aortic valve or coarctation of aorta. If they ask you the type of congenital heart disease in Down syndrome, then that is called as endocardial cushion defects. Endocardial cushion defects. So do revise this part as well. So question number 44, 45 I have already discussed. Question number 45. Which of the following condition ovarian function is normal? Turner syndrome, Swyer syndrome, androgen insensitivity, or MRKH? Turner syndrome, there is ovarian dysfunction. Okay, so there are streaked ovaries. Swyer syndrome, there is undescended testis, there is no ovary. Androgen insensitivity syndrome, there is undescended testis, it's not ovaries. MRKH, it is a type of Mullerian agenesis, and Mullerian agenesis, I have told you that ovaries are normal. Question number 46. Most common cause of hirsutism, menstrual disturbance occurring in a young female. Hirsutism and menstrual disturbance, you already know it is PCOD, provided that other causes of menstrual disturbance and hirsutism you have ruled out. So congenital adrenal hyperplasia, there will be pre-pubertal hirsutism, there is amenorrhea. In androgen secreting ovarian tumor, there can be clitoromegaly, there can be virilization. So these options do not fit into this question. It is PCOD clear cut. Okay, next. Rotterdam criteria, you should know. There is hyperandrogenism, there is ovarian dysfunction, and ultrasound shows polycystic ovaries. You can get an image-based question of ultrasound image-based question of polycystic ovaries as well. Okay. So these are some of the presentation. You can get an image-based questions like acne, alopecia, hirsutism. This is seen in PCOS. Okay. Now, question number 48. What is the first line management in obese PCOS patient? Is lifestyle modification. Lifestyle modification. Drug of choice for infertility in PCOS cases is ovulation induction. Now, letrozole is being preferred over clomiphene citrate. Okay, letrozole is preferred over clomiphene citrate. Most common drug to cause ovarian hyperstimulation syndrome is HMG injection because it will directly stimulate the ovaries. Best drug for the management of symptoms of PCOS drug, it is OCPs. Differential diagnosis of PCOS is congenital adrenal hyperplasia, late onset. Surgical management of PCOS patient is laparoscopic ovarian drilling. First investigation to be done in suspected PCOS patient is serum testosterone level. Okay, and it is 70 to 200 nanogram per ml for PCOS. Next, 49. This is a question on premature ovarian failure, or it is called as primary ovarian insufficiency. Ovarian failure occurring before the age of 40 years. Investigation is FSH elevated more than 40 international units. Treatment of secondary amenorrhea is estrogen plus progesterone. Treatment of infertility is IVF using donor oocytes. Okay, so students, you can pause the video and you can take down the notes as well. This is very important. Question number 50. Which of the following is an absolute contraindication for an IUCD insertion? Is it history of previous PID? No. History of present PID is an absolute contraindication. Scarred uterus? No. Anemia, no. If it is anemia, we can always do an LNG IUCD insertion, that is a Mirena insertion. So unexplained vaginal bleeding, because that can be a presentation of underlying genital tract cancer, and like underlying genital tract cancer or suspected genital tract cancer is an absolute contraindication for any IUCD insertion. Okay, so just revise this part. Question number 51. So again, I'm discussing some of the single liners. Choice of contraception in a newlywed female is OCPs. Choice of contraception in promiscuity. Promiscuity means multiple sexual partners, is a barrier contraceptive to prevent STD, PID or HIV/AIDS. To prevent STD, PID and HIV, again, it is a barrier contraceptive. Couple living in different cities meeting occasionally is a barrier contraceptive. Point number 52. Choice of contraception in a lactating female is mini pill, although subdermal implants can also be given. Female with menstrual disturbance, OCPs. Spacing contraception, IUCDs. Most commonly used postcoital contraception is LNG pill, which is 1.5 milligram single dose. To prevent ovarian cyst and ovarian cancer, it is oral contraceptive pills. Question number 53. A 30-year-old female was using a copper T. Now she has come with 8 weeks amenorrhea and copper T in situ, where thread is visible. What is your next step? This I have already discussed. Whenever a copper T thread is visible, always your answer is remove the copper T and give her a choice of MTP. So remove the copper T and give her a choice of MTP. You're not removing copper T because it is a source of teratogenic. Copper T does not cause any congenital malformation, but it is a source of infection. So remove the copper T because it is a source of infection. Then you might get a question on timing of IUCD insertion, which I have already discussed in my previous videos. You can go through. Question number 54. Identify the type of contraception: laparoscopic, hysteroscopic, mini pill or none. This is a hysteroscopic sterilization, and this is Assure, which has been put in the fallopian tube via the hysteroscopic guidance, and this causes like epithelialization and permanently blocks the fallopian tube. Now question number 55. A 32-year-old female para 2 L2 comes 4 days after unprotected coitus asking for a contraception. Now, if it is within 72 hours of unprotected coitus, we will give LNG pill or hormonal contraception. If it is coming within 5 days or 72 hours have crossed, then we will give copper T. So, the correct answer to this question is copper T. Question number 56. Antra. What is Antra? Antra is DMPA injection. Okay, this is a contraceptive method of choice in sickle cell anemia females. Just remember, and this mechanism of action, it is inhibiting the ovulation. This is very, very important. And remember, it is a LARC contraceptive, long acting reversible contraception. Okay, but the most common side effect is it causes irregular vaginal bleeding, and number 2, it decreases the bone mineral density, so it is not applicable for long-term use because in young females there is a risk of osteoporosis. Okay, just remember. And if the failure rate is asked, just remember 0.3 per 100 women year. Fine. And this is available free of cost in government supply with the name of Antra. Question number 57. Which of the following is an absolute contraindication of OCPs, diabetes, obesity, hypertension or impaired liver function? So the answer is impaired liver function is an absolute contraindication, whereas diabetes, obesity, hypertension are relative contraindication. So you can go through the videos where I have mentioned absolute contraindications of IUCDs. Question number 58. Now the genital tract cancers. If a female presented with postmenopausal bleeding, what is your first line of investigation? You will do transvaginal scan to check for endometrial thickness. cutoff value for endometrial thickness in a menopausal lady is 4 mm. If she is presented with bleeding and the endometrial thickness is less than 4 mm, you can keep the patient on follow-up. If the bleeding is occurring again, or if the size of the endometrial thickness is more than 4 mm, then in that case, you can go for endometrial sampling using a pipple. Endometrial sampling using a pipple. But if the endometrial thickness report is coming more than 4 mm or endometrial sampling report is coming negative and bleeding is persisting, in that case, the gold standard is hysteroscopy. Hysteroscopy followed by hysteroscopic guided biopsy. Then that becomes the gold standard investigation. Okay. So if a female presented with postmenopausal bleeding, first investigation to be done is transvaginal scan to check for endometrial thickness, because atrophic endometritis can also lead to a bout of postmenopausal bleeding. If endometrial thickness is more than 4 mm, okay, then you can go for endometrial sampling using a pipple. If the report shows positive, it can be endometrial cancer or endometrial hyperplasia, so you can treat. If it is, and you can further evaluate the case before giving the treatment. If it is, like focal thickness, or it is some space occupying lesion, or the report shows negative but bleeding is persisting, in that case, you can go for a hysteroscopy. Okay. So this is a pipple and this is a Carmen's curette. Image-based questions have also been asked in the exams on this. So just remember, this is a pipple for using an endometrial sampling or a Carmen's cannula. Question number 60. Causative agent for CIN3 or cancer cervix, all of you know, is HPV 60. Okay. Then you should know the vaccine, HPV vaccine, the age group. HPV vaccine is Gardasil vaccine, which is a quadrivalent vaccine against HPV 6, 11, 16, 18. Timing according to WHO is between 9 to 26 years. Ideal time is 11 to 12 years. Then you should know the before less than 14 years, it is 2 doses. After 15 years, it is 3 doses, 0, 2 and 6 months. Okay. Then you should know the Gardasil 9 also, which is a nonavalent vaccine. HPV 6, 11, 16, 18, 31, 33, 45, 52 and 58. These are the nonavalent vaccine. Then you should know the most common type of cancer cervix is a squamous cell carcinoma. Okay, most common type of cancer cervix is squamous cell carcinoma. Fine. Question number 61. Colposcopy, which color filter is used? You are using 3 to 5% acetic acid while you're doing a colposcopy, and you can take a biopsy from acetovyte areas. But what type of filter is being used to check for abnormal changes? That is a green filter is being used in colposcopy. Fine. Now, HPV vaccine. HPV vaccine is derived from which HPV viral protein? It is L1 viral protein. Just remember, this is again a very important question. Question number 63. A couple came to infertility clinic. Semen analysis is normal. Ovulation studies is normal. HSG shows bilateral tubal block. In my image-based question sessions, which is again available on the YouTube, I have given the image of tubal block on HSG. You can go through. And what is the next line of management when HSG shows tubal block? HSG is a preliminary investigation. It needs to be confirmed. So confirmatory investigation for a tubal patency is always laparoscopic chromotivation. Friends, doing a confirmatory investigation has an additive advantage that you can check the patency of the tube by laparoscopic dye test. Plus, if there is an associated adhesion, because there can be two conditions coexisting in cases of infertility. If it is an polycystic ovaries, you can do laparoscopic guided ovarian drilling. If there is adhesions or any component of endometriosis, you can do adhesiolysis using a laparoscopy. So again, HSG finding of the tubal block has to be confirmed with laparoscopy. And if you are asked what is the best management for a bilateral tubal block on laparoscopy, that means they have confirmed it is a tubal block, then treatment of infertility in that case will be IVF. Okay, treatment of infertility in that case will be IVF. Question number 64. Name the type of uterine anomaly shown in this image. This is an HSG image and you can see only one side of the uterine horn is being seen and one side of the fallopian tube, the spill of dye is seen. So this is no other than unicornuate uterus. So similar question was asked in FMGE exam 2020. Okay, so image based question. So do revise this session. Question number 65. A female presented in the OPD with vaginal discharge. Identify the causative agent. So what do you see in this image is clue cells. So many bacteria are being attached to the vaginal epithelial cell. So this is Gardnerella, bacterial vaginosis. Question number 66. A 30-year-old female came to gynae OPD with complaints of vaginal discharge, no evidence of genital ulcer. Okay, vaginal discharge. So this is vaginitis and no lower abdominal pain. What is the color kit? So green color kit is for vaginitis, gray color kit is for cervicitis. Usually in gynae this is important, rest you can read in the dermatology. Okay, but I have given you explanatory image, you can go through. For a gray color kit is for cervicitis, green color kit is for vaginitis, white color kit is for a non-herpetic genital ulcer, and blue color kit is those allergic to penicillin, herpetic ulcer is red, and PID. So for us, what is important is PID, what is important is vaginitis in gynae, in OBG. Okay, and gray color kit is for cervicitis, but for dermatology all other kits are important. Okay, so this is 67. Now 68, I have given you an image of this or a classification of uterine anomalies. You can go through. If by chance they ask you a very difficult question that unicornuate uterus belong to which class of uterine anomalies, so you can say it is class 2. Or bicornuate uterus or septate uterus belong to which class, so you can go through this classification. This is very important. Most common uterine anomaly leading to abortions or infertility is a septate uterus. Best modality of investigation for diagnostic purpose is 3D ultrasound or MRI. But best investigation for the treatment is hysteroscopy plus laparoscopy. Okay, hysteroscopy plus laparoscopy. Question number 69. All are sex cord stromal tumors except fibroma, granulosa cell tumor, dysgerminoma, or trichomas. Dysgerminoma is a germ cell tumors of ovary. So remember the classification. Class 1 is surface epithelial ovarian tumors. Please revise. Number 2 is germ cell. Number 3 is sex cord stromal ovarian tumors. And number 4 is metastatic, which is Krukenberg. Fine. So there can be a question on classification. There can be a question on tumor markers. There can be a question on the histopathological finding of ovarian tumors like Samoma bodies, serous tumors, Cole-Exner bodies, granulosa cell tumor, or Schiller-Duval bodies, yolk sac tumor. Okay, so just revise. Question number 70. A 25-year-old female presented with dysmenorrhea, menorrhagia, inability to conceive. So this is a classical presentation where uterus is normal size and adnexal mass. So what is this bilateral adnexal mass? This is chocolate cyst. So chocolate cyst ovary or endometriosis is occurring in a young female presented with dysmenorrhea. That is the most common symptom. Most common symptom for endometriosis is pain like congestive dysmenorrhea. There is infertility, there is dyspareunia, there can be an adnexal mass, there can be menorrhagia. So this is no other than endometriosis, and the gold standard investigation for endometriosis is laparoscopy. Gold standard investigation for endometriosis is laparoscopy. Question number 71. 28-year-old female presented with dysmenorrhea, dyspareunia with bluish nodules in the pouch of Douglas. This is again endometriosis I have just discussed. Endometriosis means presence of endometrial glands and stroma outside the uterus. Most common site is the ovary, which presents as a chocolate cyst ovary. It can be pouch of Douglas, or there can be appendix, sigmoid colons, or other areas. Okay. Next. Question number 72. Dysmenorrhea with a tender uterus. Dysmenorrhea with a tender uterus is adenomyosis. It can be a clinical question like 40-year-old female with dysmenorrhea. On examination, uterus is uniformly enlarged, 12 to 14 week size. It is tender. Then that is adenomyosis. Question number 73. Management of red degeneration of the fibroid. Management of red degeneration of fibroid is a conservative management only. Okay. So I have made you revise the obstetrics and gynae, which is looking at the 5 years pattern of FMG exam. There can be image-based questions. Okay. On the contraceptives, image-based questions on the placenta previa, abruptio placentae, like there can be an image-based question on imperforate hymen, on the polycystic ovaries, etc., which I have just mentioned. Then there can be a clinical questions. If I consider the obstetrics, it is preeclampsia, eclampsia, it is APH, placenta previa or abruptio placentae, it is complications of third stage of labor, PPH, acute inversion of uterus or amniotic fluid embolus. It can be the diameters of the fetal skull or maternal pelvis. It can be on the normal labor. It can be in the topic of twins, abortions, MTP. Okay, these are important. Sometimes, rarely, they can be on heart disease, etc. In the gynae, disorders of menstruation, contraception, then there can be infertility, ectopic pregnancy, trophoblastic tumors, cancer cervix, endometrial cancer, ovarian cancer, like endometriosis, adenomyosis, fibroid uterus, vaginal discharge, PID, tuberculosis, etc. So whatever according to me was the guess questions, images, clinical questions, single liners, all that I have discussed. So prepare well for your upcoming FMG exam. Go through the videos, this video, as well as the last 5 years PYQs of FMG exam, which is all available exclusively on NExT YouTube channels. Thank you and all the best.